Sure.
Good morning, all. We'll be continuing with our blood culture cases for this week. The first case, we have an 81-year-old female presented with a CVA, hemorrhagic stroke in the cerebellum, for which a posterior fossa decompression was done. She later developed collapse of her left lower lobe, the lung, due to mucus plug. The mucus plug aspiration was done. This was all in the post-op period. Subsequent CSF samples sent for this patient, we detected human herpesvirus 6 via a biofile. So, post which she also had a lot of seizure episodes. This patient also has a problem of chronic osteomyelitis post an RTA which happened 10 years back. She also has uterine prolapse. She has other comorbidities in the form of systemic hypertension and diabetes mellitus, for which she's been taking medications. So this is a case which has a lot of comorbidities associated with it. So this is the imaging report which we got, showing bilateral intraparenchymal hemorrhage in both the cerebral hemispheres. This also associated subarachnoid hemorrhage and thin tentorial subpleural hematoma. There's also intraventricular extension to third and fourth ventricles. So here we're able to see a biofile report of HHV6 getting detected. HHV6 usually it affects which part of the brain? Usually affects the limbic cortex, causes a lot of memory loss and again seizures, even cause hyponatremia. So in this case, we have this patient having seizures since the detection of HHV6 and in the post-op period. It can also cause conditions like acute disseminated encephalomyelitis, edema. There are case reports where HHV6 has also been associated with a lot of arterial ischemic infarcts, a lot of vasculitis. But here in our case, we had a hemorrhagic stroke. We have to look into the association of it. So this is the chronology of the cultures for this patient. Patient is with us from the 30th of April. So from 3rd of May they've been sending us cultures. Several cultures, ET aspirate blood, urine, sputum, pus, CSF. So the pus is from the chronic osteomyelitis. ET aspirate we had reported as E. coli because they initially submitted it as they raised the test under pus. So apart from that, all the cultures came out to be negative except for the CSF which detected HHV6 on a biofile. After this 20th, this is the recent blood culture sent both the bottles. Group carbapenem resistant Escherichia coli having the phenotype of a New Delhi betalobetalactamase co-producing a CTX-M ESBL as well. So why I have highlighted this is, even in our lab, the most common carbapenemase phenotype which we are seeing is NDM, then OXA, most likely co-producing with an ESBL, specifically CTXM. And in a recent study in Thailand, they have detected almost 75% of their carbapenemase strains follow the same pattern. And when looking into the reason why this is happening, one thing which is common, which you all know, is this widespread use of carbapenems. But why this specific co-production of NDM and CTXM is that the NDM usually detected in these cases is NDM5, and this NDM5 and the CTXM genes, they are often found together on the same transferable plasmid known as INCF type plasmid. So their loci are very close to each other, and when that part of the plasmid gets transferred, so that is why you're able to see this both CTXM and NDM5. So a single transfer event happens. So because both resistant genes are encoded on the same plasmid, a single horizontal gene transfer event can simultaneously confer resistance to both carbapenems and cephalosporin, so NDM and ESBL. So that is the reason why we get this quite often. Coming to the CSF which has been sent, so one sample was sent on the 8th and the other sample was sent on the 30th. Initially there was a lot of neutrophilic pleocytosis, later it became lymphocytic. So because the ADA was elevated more than 40, in this patient. They are also suspected it to be of tubercular origin and gene expert MTB was sent, which was not detected. So we have a diagnosis of a bloodstream infection with the Escherichia coli carbamase producing organism, and we have a CNS insult in the form of a stroke. Could this possibly be post an HHV6 infection? So this is her left knee. You are able to see this. This is the RTA scar. And here we are able to see a small sinus which is draining scanty pus. So we are able to see the trends in CRP and procalcitonin. Procal, the highest value being 0.32. It is now in the decreasing trend. The CRP has now elevated from 13 to 113. These are the list of antimicrobial agents and other medication the patient is on. She is on linezolid for the chronic osteomyelitis. They are trying to cover MRSA. Valganciclovir she is getting for the HHV6. Again, the problem with valganciclovir, she is getting it through the RT feed, and how much it is going to concentrate in the CSF, we have to look into that. And again, for the carbapenem resistant E. coli in this case, they started ceftazidime avibactam and astronam. Astronam is going to take care of your NDM, and this avibactam is going to take care of your ESBL, CTX-M. So she's on a lot of anti-epileptics, she's on antihypertensives, and she's on insulin for glycemic control. So there are a few case reports and papers describing this HHV6 infectious encephalitis and even stroke syndrome associated with HHV6. There is another systematic review of not HHV6 but the whole herpes group of viruses, which in turn can cause stroke-like presentations. So now this patient is currently in CCU. So in view of comorbidities, her counts have come back to normal, but only her CRP is elevated. There are no fever spikes. Patient is being monitored.
So the cause of CRE sepsis we don't know. Why was it?
Sir, urine is clear, sir. Urine is not the cause. Patient has multiple lines, sir. Apart from that, patient status post tracheostomy. Very good. Coming to our second case, we have a 40-year-old female who presented with a distal gangrene of the left index finger. On CT angio imaging, it was found that she had a thrombus in her left brachial artery. So for this, there is a catheter-directed thrombolysis done via right femoral axis. Post-op day 1, day 2, she started developing fever and bullous lesions around her femoral axis site. She was being treated with antibiotics that later extended into the retroperitoneum. She had huge collection in the retroperitoneum that was opened and evacuated. The femoral arteries were involved, so they had to do a bypass grafting with the PTFE Teflon. She also had oral ulcers due to HSV. So with this picture, she has a prothrombotic state. So the cause for this prothrombotic state is being evaluated, and APLA is being one of the important DDs for this case. So coming to the culture sent for us, this is the initial culture both from blood and pus. This is not the one for this week's. This is the one which was sent when the bullous lesion started forming and later when the retroperitoneal abscess was evacuated. So we grew Staphylococcus aureus from that lesion and the corresponding blood samples. It was an MRSA. Clindamycin was resistant. Teicoplanin had the highest breakpoint to MIC quotient. We started her on teicoplanin, a loading dose of 12 mg per kg followed by maintenance dose of 6 mg per kg, and clindamycin was also started in spite of it being resistant for the antitoxin effect. So this you are able to see her leg through which the femoral axis was done. You are able to see these disseminated bullous lesions. Now is healing. So when we had gone for referral for this patient later, when the counts are increasing, we had again increased the teicoplanin dose from 6 mg per kg per day to 12 mg per kg per day. Clindamycin was stopped because the antitoxin we usually say only 3 days we give. Rifampicin was added because of the vascular graft. Then there are I'll show you a few studies where rifampicin is a very good agent to prevent or eradicate biofilm formation, especially from vascular grafts and bone implants. Piptaz was added as a general gram-negative and anaerobic cover. Injection acyclovir was there for the oral ulcers. In this case raises an important question regarding echo screening, because again in patients with diagnosed APLA, since the patient has a prothrombotic state, any prothrombotic state for that matter, it is always better to get an echo screening done and rule out infective endocarditis. And we also wanted to rule out other such pathogens which can present with a similar presentation post such intervention. We wanted to rule out non-tuberculous mycobacteria and fungal as well. So cultures for those appropriate agents have been sent as well, because NTM like Mycobacterium abscessus can also present with a similar picture of disseminated skin and soft tissue infection post intervention. So coming to this week's blood culture, so the patient was successfully treated for that gram-positive cover. So subsequently, she developed a bloodstream infection with Acinetobacter baumannii, carbapenem-resistant Acinetobacter baumannii. Both blood cultures grew the same organism, and we had asked them to de-escalate teicoplanin after the pus culture, because the pus was still growing staph aureus. So we asked them to add ampicillin sulbactam for the Acinetobacter baumannii with minocycline, starting as high dose 200 followed by 100 mg as maintenance. So here you are able to see our biofire, which was done for the blood culture even before the cultures came out to be positive. We had Acinetobacter baumannii detected on our biofire. It also had Staphylococcus epidermidis in one of the samples, which is a contaminant. This is the case publication from a lupus journal, where they found the association between APLA, infective endocarditis, and sepsis by staph aureus. So I found this paper was something in the lines of our case. So what they wanted to assess antiphospholipid syndrome in association with higher odds ratio for infective endocarditis and staph aureus sepsis. So they found that the odds ratio was there, but there is no significance. There is a significant odds ratio, but no significant difference in the inpatient hospital mortality within the IE group having APS and not having APS. So they still say APS is an independent risk factor for infective endocarditis and staph aureus sepsis. This is the paper which I was talking about, where rifampicin is being used for graft removal and associated with better outcomes with prostatic vascular graft infection. So our patient had when the retroperitoneal abscess was being evacuated, they saw a lot of the femoral arteries, femoral vessels being involved. So they used the iliac graft with the Teflon, and they corrected that vascular insult. So here rifampicin is being continued for this patient. Moving on to our next case, we have a 30-year-old female who is a known case of MOGAD antibody positive. MOGAD is myelin oligodendrocyte glycoprotein antibody associated disease. Also has Takayasu arthritis. Also has PMOS, the new name for PCOS. She presented with complaints of swelling and oozing of fluid from her face, scalp, and ears over the last 1 week period of time. The patient was on carbamazepine, so they initially thought it is a drug-induced SLE or a DRESS syndrome. Patient is on IV methylprednisolone. A lot of the lesions have decreased. 7 days back, patient had some lower UTI symptoms and was started on nitrofurantoin. After coming here, because of the skin lesion, she was also started on injection clindamycin as a staph cover. We are also getting topical mupirocin. Blood culture sent on 18th. Both the bottles grew Enterococcus fecalis in this case with the highest BMQ for teicoplanin. So patient was started on doxycycline initially. We had also asked them in view of increasing counts, So in view of increasing Procal to start Teicoplanin. So the interesting thing about here is steroids can affect your count, steroids can affect your CRP levels, but effect of steroids on Procal is not as much as it is that on your counts, your WBCs and your CRPs. So Procal can be used in this case. It won't give you false negative report. No patient is on Teicoplanin 12 mg per kg followed by 6 mg per kg and doxycycline 100 mg BD. So this patient, her lesions have also improved. Her counts, CRP, Procal all normalizing. Fever because of the prednisolone we are not able to assess, but patient is fine. She's in the dermatology ward as of now. We also had a fourth case, but the patient went on LAMA. We had a Candida tropicalis isolate from blood culture. Patient had a blunt abdominal trauma with hollow viscous perforation. There was exploratory laparotomy and colorectal resection and anastomosis done. So as we know, with GI surgeries or hollow viscous perforation, we get candemia. So this patient was with us only for a period of 1.5 days, post which went on LAMA. After that only our blood culture report came. So when patient was here, he wasn't started on echinocandin. So this is with respect to all our 4 cases of today's blood culture.
In the previous case of this APLA and Beckett's disease, as a PDCC student, you should know what are different types of Teicoplanin loading regimens. I think there were 3-day regimens there. I think there were 5-day regimens also there. So how many loading doses you want to give and what are the conditions which you have to just go through that in case?
Here we are giving a loading dose of 12 mg per kg twice a day on day 1. Day 2 is 12 mg per kg OD. Day 3 is 12 mg per kg OD. From day 4 onwards it is 6 mg per kg OD if it is not an orthopedic infection. If it is an orthopedic infection, you continue the 12 mg per kg throughout. If it is a non-orthopedic or a deep-seated infection, you continue with the 6 mg per kg OD.
Okay, thank you.